Welcome to the Royal College of Physicians. My name is Natalie Craven. I'm Public Programmes Officer at the RCP Museum. Welcome to our RCP members and fellows, our exhibition regulars, and those of you visiting us for the first time. I'd like to thank the Life of Breath research team for putting together the content of tonight's evening, which we're delighted to host. To the RCP's National Asthma and COPD Audit Programme, over here, for being here, and final thanks to my colleagues in the museum and the museum volunteer team for supporting this event. Tonight we'll hear 5 short presentations, then a panel discussion chaired by Jane McNaughton, Principal Investigator on the Life of Breath team. After the panel discussions, we'll open the floor for some questions, and then if you'd like to share any comments on social media, please use the hashtag #CatchYourBreath, and please do follow us on Twitter, Facebook and Instagram. We are at RCP Museum and at Life of Breath. This evening's event is being filmed and will be online on the Life of Breath YouTube channel shortly afterwards. After tonight's discussions, please do visit the exhibition Catch Your Breath outside on this level and join us for some drinks downstairs as well. And if you don't have time to see the exhibition this evening, the exhibition is open until the 21st of September. And please do have a look on our website for our forthcoming public events programme. I'd now like to invite Jane McNaughton to introduce this evening's topic and the speakers. Thank you very much.
Thanks, Natalie. Well, can I just add my welcome to everybody this evening. It's great to see so many people in such a beautiful, warm summer's evening, especially when we've got Regent's Park so close by. It'd be a nice place to be. But I'd like to just introduce myself. I'm Jane McNaughton. I'm Professor of Medical Humanities at Durham University, and along with Professor Javi Carroll here on my left, we are the 2 leaders of the Life of Breath project. And I'll say a little bit more about that in a minute. Before I want to introduce the rest of the panel. Just a bit more about me. I am a clinician. I don't work in respiratory medicine. I was a GP, so I have some familiarity with the condition, but we do have somebody who's an expert on the panel with us this evening. So first of all, if I'd like to introduce Javi Carroll, Professor of Philosophy at the University of Bristol, and she is the other PI on the Life of Breath project. Next to her, Dr. James Dodd, who's a consultant respiratory physician at the University of Bristol and Southmead Hospital. And then next to him, Dr. Alice Malpass, who's a senior research fellow in the Department of Population Sciences at the University of Bristol Medical School. And next to her, Dr. Corinne Maguire, postdoctoral research associate in history at Bristol and part of the Life of Breath project as well. And you'll see the reason why I got the name wrong. We have Corinne Saunders next to her, who's Professor of Medieval Literature at the University of Durham. So as you can see, quite a mixed bag of different disciplines for you this evening. I wanted to kind of introduce the project and a little bit about the theme that we're going to be thinking about this evening. As you've just heard, we're sitting adjacent to the Life of Breath project exhibition, which is called Catch Your Breath, and that's based on our project's research that I've already said, led by Javi and myself. Life of Breath is a 5-year medical humanities project funded by the Wellcome Trust, to whom we give great thanks for supporting this evening's event and the exhibition. The project, The Life of Breath, explores the symptom of breathlessness, bringing together a range of disciplinary perspectives from philosophy, anthropology, looking at the literary, cultural, historical, and clinical perspectives in order better to understand the complexity of the relationship between lived experience and this symptom. And also because we believe that breathlessness as a symptom and as a sensation needs interdisciplinary engagement to untangle its complexity in order more effectively to help people who suffer from it. So our work over the last few years has uncovered the cultural origins of the understanding of breath and breathlessness, has examined the ways medicine has created the language and technologies that define it, and has delved deeply into the experience of living with breathlessness, which we believe is essential to good management. We've also, through this exhibition, which had a run in Durham as well, and will go on to have a run in Bristol, and we've worked especially through the exhibition with British Lung Foundation Breathe Easy groups, focused on helping to bring this neglected and invisible symptom out into the open. So you'll see that I've been speaking about breathlessness rather than dyspnea which is the clinician's word for it. So that is an attempt to avoid a wholly clinical view on this. But you'll also notice that we avoid confining the symptom into any disease category. We are interested in the symptom rather than the underlying cause. And that's why one of the themes that's caught our eye and concerned us in this project has been the problem of so-called symptom discordance. That's when objectively measured lung function in the clinic gives us one answer, but the patient experience gives us another. Lung function might be good, but the person might still feel quite breathless, and vice versa. This kind of discrepancy between how medicine measures things and people or patients' experiences is core to our medical humanities interest across a range of disciplines, as you'll hear. And we've been investigating the reasons for it. Why is this discrepancy important for us as clinicians and for people as patients? Well, that's related to the clinical approach to symptoms. As medics, we're trained to think of symptoms not as an end in themselves, but as an indicator of what is really wrong with the person, the actual physiological problem. So, that's me. And this is the slide I was going to show you. The actual physiology. This recent book, which I've been looking at, on interoceptive awareness. Interoceptive awareness is how we experience the internal sensations of our bodies, points this out and says that the accuracy assumption, that is the assumption that what patients say they're experiencing about their symptoms accurately reflects their measurable physiological state, is a fundamental contract implicit in the relationship between patient, physician, and healthcare system. It's the reason why people come to the doctor and doctors make diagnoses and assess recovery on the basis of accurate symptom perception. But it seems that in the case of a complex sensory experience like breathlessness, or indeed in the case of medically unexplained symptoms, which is an increasing thing we're hearing about, this contract breaks down. So our panel this evening are going to explore some of the reasons for this, and they'll speak for about 5 minutes each, and then we'll look at some themes that might emerge from that collaborative set of talks, and then we'll open it out to you for some questions and discussion.
Thank you. So you'd tell a philosopher to talk for 5 minutes. That's that'll be quite a challenge. Okay, so I'm a philosopher, and what we do, one thing we do is we work with concepts. And I was thinking about this seemingly innocent word, breathlessness or breathless. And I was thinking, what do people mean when they say they're breathless? Do they mean that they are lacking in breath, that they have less breath than they should or less breath than other people? When they talk about catching their breath, do they think of themselves as chasing it somehow? And I think what happens in our research project is that we honed in on this word, this term, breathlessness, and we thought we should treat it with anything but acceptance. We should be suspicious of it. And that suspicion led me to think of breathlessness as a term that actually hides rather than reveals, or that masks rather than uncovering some of what people who are pathologically breathless mean when they talk about themselves being breathless. So we use the same term, breathlessness, to express both normal and pathological breathlessness. And what I think this does is obscures the really quite profound differences there are between these two experiences. So moving away from the concept to the kind of experience we might try and represent by that concept. And if you think about it, if you are able-bodied and don't have a respiratory condition, the kind of breathlessness you might experience is of a very different sort to what somebody with a respiratory condition might experience. It will be benign and non-threatening. Indeed, it can also be pleasurable if you like exercising or enjoy exertion, or if you're testing your physical limits in a sports challenge, for example. It's not experienced as a limitation, but as a natural engagement with your body's capacities. So if you think about the fact that we're all unable to fly, for example, or breathe underwater. We don't experience these limits as deficiencies. We just experience them as part of the conditions of our human embodied experience. But in pathological breathlessness, in contrast, that experience is very different. So the breathlessness is experienced as a limitation, and more significantly, it's experienced as something that is frightening, that is foreign, that is unpleasant, and that is deeply unsettling and threatening. So the first thought I'd like to offer is that when those of you who are health professionals sit in the clinic and exchange that word, breathlessness, with a patient, does it arouse suspicion in you? Do you feel that the word might not mean the same thing to both people, both parties at the table, as it were? And secondly, thinking about whether using this word to cover this enormous spectrum of sensations and experiences actually might end up reducing health professionals' capacity to appreciate the unique qualities of pathological breathlessness. So I've talked about it being experienced as a limitation. I now want to offer a second characterization of it as negatively experienced. So it's not just that it limits you from doing things you want, but that experience of limitation is a deeply negative one. It is an experience of deficiency, ineptitude, inability to be the same as other people or to do the same as other people, inability to measure up against your own goals or standards, or maybe how you once were before you had the respiratory condition. And then finally, the interesting thing, I think, philosophically for me, was to think about these two parts of the spectrum, the normal part of the spectrum of breathlessness versus the pathological part of the spectrum of breathlessness, and to think of the pathological experiences as enriching our ability to understand our human bodies and our capacities, because it stretches that spectrum. It forces it to expand into what can be quite extreme experiences. So I've not had an experience of it personally, but I've read and heard accounts of people talking about, for example, having a pneumothorax as a very extreme experience, of people who've had chest drains inserted, as feeling profoundly violated by that experience, not to mention uncomfortable and in pain. And of course, if we think about the liminal experiences of breathing right at the end of life, that, again, is a profoundly extreme and unfamiliar experience. So one of the things that we've been thinking about a lot in the project is how are we able to, first of all, make these experiences, which are largely unspoken by the very breathless patients, that are largely invisible, because if you think about the experience of breathlessness, it might be personally very overwhelming, but externally it can be very undramatic. Somebody stopping to catch their breath, you don't see anything, there's no massive bleeding or anything externally exciting going on. So we have the spectrum and we operate with it very differently. People who have not had experiences of pathological breathlessness might be implicitly referring to the narrow spectrum of normal breathlessness, while the respiratory patients or those who suffer from respiratory conditions might be referring to the pathological band of the spectrum, if you like. And one of the questions is, how do we make that word breathlessness do more work for us? How do we make a finer or a more a richer distinction between different kinds of breathlessness that might ultimately be associated with different underpinning conditions, respiratory, cardiac, psychiatric, and so on. So I'm offering this by way of sort of opening remarks to say we should really be acutely sensitive that the terms we use in the clinic might, to an extent, be insufficient. Thank you.
Right, thank you very much. So I'm going to share a few minutes about the clinical perspective, which is likely to be more familiar territory for most of the people in the room. So it's been a privilege to be part of this project and learn so much from so many different disciplines that I've not had contact with before. My role is to be the clinician in the room, to be the tame clinician, to provide a bit of insight into this process, and it's been fascinating. So just a few things that I thought that we could talk about just to get some ideas flowing. So from day one at medical school, we're taught that somebody who reports that they're breathless is important, and it's a potent predictor of mortality. So some of you, the clinicians, will be familiar with these types of graphs, and what we've got here is that somebody who's saying that there are different grades of breathlessness is a better discriminator of mortality and risk of death than a lot of objective measures we get. So this is drilled home to us in the day one of medical school and throughout our clinical training. So we know it's important, and it seems to be a critical kind of warning sign of an imbalance in homeostasis within the human body. And the graph on the right of the screen will show you that actually that our measures of lung function and symptoms just don't correlate, and that's don't correlate very well, and that's again at the essence of what this project is about. We know that breathlessness is common, and studies that just asking members of the general public whether people are breathless, 10% will report that they're breathless. That goes up to 30% in elderly populations. So we're starting to think, well, actually, yes, it's important, but it's also very common. Is it a range of normal? And it brings back to this idea of what is breathlessness to different people. But if they're asked that question cold, then 30% of elderly people report that. Is this therefore part of normal aging to report breathlessness, and whatever that means? So coming into the clinic, here are some visual clues about what you might expect to undergo as part of your assessment in a respiratory clinic. I suppose that we're tasked in the respiratory clinic to do two main things. One is to try and make a diagnosis. Somebody's reporting a problem with breathing. People want to know what is wrong. And even if we've made a diagnosis, then why are we worse than we were? Why are we more breathless than we were? Is there something that we can do? Is there something that we can measure about the severity and the trajectory of our illness? Those are the kind of things that we're trying to do. So how do we do this? Now, we've talked about lung function, and we'll talk about that a little bit more. But actually, I think all the clinicians in the room will appreciate that the essence of what we do is to take a good history. We listen, and we talk, and we have open questions, and that's the art and the fun of medicine, is to have that discourse. And that's where we will be trying to tease out the diagnosis as much as anything. We'll then be supplementing that part of the consultation with some objective measures. And we've got a body box here, plethysmography, lung volumes, airflow obstruction, and efficiency with which we're absorbing various oxygen. We do functional tests of walking. We can even get people on treadmills and cycles and exercise both heart and lungs and see how they respond. But breathlessness is a subjective symptom, and therefore, in order to measure breathlessness, the only person that can tell us that is the individual, is the patient. And so, therefore, we're not measuring breathlessness with any of these tests. We're measuring pathology. We're trying to identify, as I say, diagnosis or trajectory of illness. If we're trying to capture, then there have been some efforts to try and do patient self-report measures of breathlessness from a simple, the MRC dyspnea score but that's an impact of breathlessness on people day to day. So, and there have been some very good progress in this area of validated tools of breathlessness. There are multidimensional tools that are trying to address the kind of emotional and affective aspects of breathlessness and try and capture them. But they have their own limitations and complexities. Are you wanting to measure breathlessness right now? Are you wanting to measure breathlessness, how has it affected you recently or over a longer period of time? What domain of breathlessness? How are people going to respond to each of these questions as an individual? It's not touching the richness of the lived experience of breathlessness, I would say. There are limitations of the objective measures, but I think one area that I'd like to raise is that objective measures, clinically, traditionally, hold greater weight than the subjective report from patients. And there appears to me to be this imbalance. And how do we appreciate that limitation and this imbalance in the clinical relationship between objective measures and subjective measures? And actually, I would say that there are clinical biases that would pay more weight to an objective measure, but there are also patient biases that they bring into the clinical room, that they expect that their symptoms will be explained by a breathing test. And actually, so there's two ways of looking at that. Those biases towards the objective. And I think that perhaps we need to talk about how we redress that balance and add greater weight to that subjective conversation, going back to the history taking. And doing that well takes time, and it takes the right language, and it takes the right sensibilities to understand how people are communicating. So I'd be interested in your ideas and your experiences about how that could best be done.
Jo Winning asks us, what is a body? What are its boundaries and contours? And how do we come to know the body through our senses? To answer these questions, Jo Winning urges us, she's writing from a medical humanities perspective, she urges us to have transdisciplinary conversations as we are this evening. We need to have these conversations across methodologies, across disciplines, in order to have what she calls new sensate and sensitive vocabularies, both in clinical practice, but also to strengthen and improve medicine's ongoing dealings with the human body. So one possible starting point for this conversation with clinical practice for me as an anthropologist is sensorial anthropology, which takes as its object of study the process of how do we turn the experience of sensations into symptoms. How does that happen? How does that come about? And so my initial contribution to this type of discussion is a critique of how biomedicine and cultures of clinical research have measured these sensorial aspects of breathlessness that James was just referring to in some of these self-report measures. So we know, and most of you will know in this room, that shortness of breath is described as a polymodal sensation. Thank you. Polymodal sensation as it derives from muscle and tendon tension in the respiratory muscles of the chest and the neck, the feeling of skin pressure across the stomach as it fails to rise on the inhale, and the gastrointestinal tract distension if the abdomen becomes distended, preventing normal inhalation. But how does clinical science set out to capture experiences of these sensations? One recent example that James mentioned is the multi-dimensional dyspnea or breathlessness profile questionnaire. It's the most recent example of a clinical team setting out to try to measure the lived experience of breathlessness. And tonight I'm going to share just one example of how the wording used on that questionnaire is often at odds with the language those living with breathlessness may use. So a recent independent comparison of the multidimensional breathlessness questionnaire compared it with other measures and reported that it was readily understood by patients. It's this assumption that I want to debunk. So just taking one example from this questionnaire, there's a statement on this questionnaire that patients or those living with breathlessness are asked to state whether it applies to their experience of breathlessness or not, and then rate it in terms of intensity, how much it affects them on a scale of 0 to 10. And this item is, my breathing requires muscle work or effort. So what's your first impression of that question? Does it sound like a reasonable question to ask someone who lives with breathlessness? Does it have meaning for you as a clinician or someone living with breathlessness yourself? For those living with breathlessness who I spoke to, there was a lot of confusion over this statement. Confusion over which muscles are being referred to here, muscles in the whole body or stomach muscles. Some were unsure what muscles, if any, are involved in breathing at all, and others describing the lungs as a muscle. And the word effort was also interpreted in many ways. It could mean the effort involved needing to stop, to control and calm the breath, or the effort involved because an activity is so overwhelming that you need help from others, or the effort involved because the quality of the air has changed, because you're showering and the air is moist. But the biggest comprehension issue, and perhaps which was surprising, was that muscle effort was questioned about whether does it involve conscious awareness or not. So, in other words, people were asking and reflecting on what is a body and who is breathing. So one man living with COPD told me in response to this statement, my breathing requires muscle work or effort, I mean, you're breathing at the moment. I'm breathing. You don't think about it. There's no muscles. Well, there are muscles, but they're natural. I mean, you don't think about that. So it's this idea of breathing being normative, and perhaps speaking back to what Javi was saying about these two breath selves. But let's ask the question, what's caused the confusion with just one item on this questionnaire? Was it because people were distinguishing between when they're at rest and when they're active? Or was it because muscle work and effort suppose some kind of conscious awareness? Is this how we think of our breathing and our breathlessness in this room? So how do we make sense of this mismatch between the language those living with breathlessness use and the language those designing respiratory questionnaires choose? So one helpful piece of work I found is Margaret Lock's work. She's a medical anthropologist, and she has this concept of local biologies. So I think it's a helpful way to maybe answer this question of why people feel the need to recontextualize, to reformulate, to contest these statements on the questionnaire. Local biologies are linked in Margaret Lock's work both to the experience and the interpretation of sensations. And in the case of many of those I interviewed, breathlessness was associated with occupational exposure to air pollutants, working as chefs or engineer. The man whose data I just shared with you had spent many hours as an engineer inspecting ships on the docks in the northeast, inhaling paint pollutants. Local biology refers then to the way in which the embodied experience of physical sensations, how they are attended to, how they are organized, how they are articulated, and how we understand them, that these are all embedded in the historical, which we'll speak to in a moment, as well as the material and the social structures framing people's lives. So perhaps what I'm saying is in my data is that the reason there's this mismatch between local biologies and the attempts of researchers and clinicians working within the biomedical model to turn sensations into measurable symptoms is that bodily experiences do not take place, nor are they expressed in a vacuum, and that we need to remember that biomedicine is just one key actor in defining these categories through which we experience and express our bodies. And our job as interdisciplinarians is to open up discussion about competing languages of meaning and open up discussion about the unexamined assumptions in the world of respiratory science and policymaking, so that we can hear more accounts of those local biologies. Thank you.
In 1963, the British Medical Journal published a letter which argued that a respiratory physiologist offering a unitary explanation of breathlessness should arouse the same suspicions as a tattooed archbishop offering a free ticket to heaven. As James has already explained, lung function measurements are kind of imperfect, and using the spirometer to represent breathlessness was problematic even in its 19th century inception by John Hutchinson. The spirometer tried to present vital capacity as a kind of proxy measure for lung capacity, and Hutchinson believed that this could be impacted by height, attitude, weight, age, and disease. So the idea that we're all breathing the same air in the same way was problematized even at the very beginning of spirometry. And data sets were specifically constructed around groups, which promoted the idea of normalcy within certain groups, or what we might term reference classes. But historically, the use of such reference classes has been variously linked to the determination of bodies as either inferior or superior. So for instance, Hutchinson didn't address vital capacity in women. He used the vital capacity standards of men as for women, rather than making separate studies. But this was actually a really unusual move to make in this time period, which was fascinated by the science of difference. Most scientists were sure that vital capacity was less in women. One study attributed this to the fact that women had a less keen need of air and argued that they would fare better at higher altitudes and working in front of hot stoves. And various theories were espoused to explain the lower lung capacity of women. And one of the most enduring was that men naturally breathed from the diaphragm, while women breathed from the chest. Oh. That is costal breathing. However, the association between corsets and costal breathing meant that this type of breath was linked with both civility and racial purity. For example, Dr. Kellogg's of cornflakes fame wrote that women who wore corsets and tight dresses gave tracings like civilized women. So costal breathing was largely regarded as an artificially created difference. But uncertainty about whether corsets were restricting breathing to the extent that it was altering vital capacity remained. And there was a great deal of confusion about, was this a sex difference or was this a gender difference? Not that they would have put it like that. But it wasn't until 1975 that the Medical Research Council proposed conducting studies that would stipulate the standardised respiratory values of normal women in Britain. And it's remarkable that it took this long. By 1844, not only did we have normal lung function values for men, we had normal lung function values for subdivisions of men. Firemen, policemen, wrestlers, small men, tall men, every man in between. But in 1979, the MRC researchers provided reference values for healthy British women for the first time. But how did they define the healthy subjects? Interlinked with the problem of appropriate reference equations is the difficulty of defining and assessing normalcy to represent a healthy population in the first place. And we can see this if we go back to 1936, when the MRC were investigating pulmonary disease among coal miners in South Wales. And their reports were crucial because they proved a link between length of exposure to coal dust and respiratory disability, which meant miners could be compensated. But adjudicating for disability was complex. It was very difficult to arrive at any kind of diagnosis using X-rays. But the spirometer offered evidence of respiratory disease in numerical terms that could be usefully used in this complex compensation network. But using spirometry in this way necessitated a definition of normal with which to make the comparison. And as we can see here, Gilson and Hugh Jones explained that this was much more difficult than the scant reference in the literature would suggest. And indeed, the MRC's 1936 clinical investigation used normal lung function values based on the miners already working in the mines. So their data sets used a normal standard set by apparently healthy miners rather than a non-mining control group, which wouldn't necessarily have mattered if the investigation involved the health of the same miners over several years. But as you can see from the map, it was comparing the health of miners in different areas to try and work out if the environment was causing pulmonary disease. But there was only one mine actually involved in the clinical investigation, and the spirometry test there was clearly flawed because it took its measure of normalcy from the very population in which abnormality was already apparent. And if causation from dust or disease couldn't be established, it followed that the problem must be related to the essential constitution of the miner. So innate biological causes and potential ethnic differences were sought in order to supersede the relevant social or environmental factors. So to conclude, I want to highlight these kind of potential negative consequences of essentializing social groups as distinct kinds to be categorized for measurement. Because historically, we can see that insistence on difference has worked to oppress already disadvantaged groups. And while it might seem intuitive to use categorical reference classes like sex or race, these classifications are based on a somewhat arbitrary supposition of relevance. And this approach risks obscuring the social causes of health inequities. Not only does it ignore the impact of biography and developmental plasticity on health, prioritising certain categories of identity can conceal others from view and can obscure the social causes of disease. Thank you.
Well, Corinne has taken you back in time to demonstrate the complicated, often subjective history of how we measure breathlessness and the cultural assumptions those measurements might conceal. So I want to leap back some 6 more centuries to a very different thought world, the world of the Middle Ages. And 2 works in the exhibition upstairs in its literary section offer different windows onto that world. They're both from the late 14th century. Chaucer's great epic romance, Troilus and Cressade, a story of the extremes of romantic love and betrayal, and the Book of Margery Kempe, the first autobiography in English, tracing the mystical experience of its female author. So what can they tell us about life and breath? Well, medieval thought inherited the classical physician Galen's theory of the 4 humours. Both physical and mental health depended on the balance of the humours, so a mind-body continuum was taken for granted. And medicine also adopted Galen's model of the so-called bodily spirits. And according to this model, the pneuma, the life breath of the cosmos, was modified into 3 kinds in the body. In the liver, the so-called natural spirits enabling generation and growth carried through the veins. In the heart, the vital spirits heating and animating the body and governing breathing carried through the arteries. And then in the brain, these vital spirits were transformed into the so-called animal spirits sent through the nerves to govern sensation and thought. Breath has a 2-fold role. It cools the heart and it generates those vital spirits which are required to create the animal spirits. So mind and body are both fueled by the breath. Breath was also intimately connected with the emotions, which were believed to occur through movements of those vital spirits. In extreme joy or anger, for instance, the vital spirits and accompanying heat were understood to move out of the heart to other parts of the body, causing, for example, the physical response of blushing. But in extreme grief or fear, by contrast, the vital spirits and heat withdrew into the heart from the arteries. And withdrawal of spirits meant withdrawal of breath. It might cause unconsciousness or even death. So in medieval thought, the swoon is a flashpoint signaling great grief, or sometimes ecstasy. Medieval imaginative fiction, or romance as it's called, relies on this physiological model in its treatment of love, which is seen as a sickness coming from the outside. It's often imagined as an arrow shot by the god of love and causing extreme physical symptoms that reflect the overburdened heart, from pallor to emaciation. Chaucer treats love in a remarkably medicalized way. So, in the example shown in the exhibition, his hero Troilus, overcome by seeing his lady Cressade weep, feels his heart close. All the vital spirits withdraw into it, and Chaucer says, down he fell all suddenly, a swoon. We can contrast this example to that of Margery Kempe, whose vital spirits rush out in an ecstasy of spiritual revelation. And we read how she's literally inspired with the Holy Spirit, overcome by extreme crying and roaring, boisterous sobbings and plenteous tears, loud cryings and shrill shriekings. I don't think this lady conveys quite that kind of extreme of noise. But Margery's repeated physical falling, by contrast, suggests the other effect of the vital spirits drawn into the heart through extreme feeling. While Kemp's behaviours are now often seen as performances of extreme devotion, they can also be read as corresponding to the dominant medieval physiological model of emotion, of those vital spirits rushing in and out of the heart. Well, what can this model tell us now? Well, we still often think in dualities, mind versus body, cognition versus emotion. The pre-Cartesian thought world offers us an embodied model of emotion. Its emphasis on the deep connection between thinking and feeling, and the association of breath with spirit and breathlessness with extremes of feeling that take the individual to the very boundary between life and death. All these help to illuminate the deep connections between mind and body that are still so evident in the experience of breathlessness sufferers. And they also illuminate the subjective nature of such experience, its profound connection with an individual's emotional state. By foregrounding the interdependence of physical and psychological experience, and the centrality of breath to emotional experience, pre-modern models can help us to probe symptom discordance, to understand the prior assumptions, conscious and unconscious, that shape experience, and the deep and complicated roots of individual responses.